All right, very good. Good afternoon, good evening. We are recording live here from Seattle on a beautiful afternoon. This afternoon, we're going to talk about Bertolotti syndrome. So our wonderful fellows have a couple cases prepared, and we'll also talk, of course, a little bit about the history and presentation, workup, treatment, diagnosis, that kind of thing. So I will hand it over directly to Mohammed, who will kick it off. And I'm just filling in for Dr. Chapman today, and hopefully he can join us for part of the discussion as well online.
Thank you, Dr. Creamer, for the introduction. So this will be the outline for today's presentations. We'll start with a brief historical overview of the presentation of Bertolotti and the clinical presentation, then about the classification. Then we'll go in separate about the resection procedures, interventional treatments, and the role of lumbosacral fixation as a treatment for this rare pathology. So to begin with, a brief histological review. Dr. Mario Bertolotti, he's an Italian radiologist and neurologist at the same time. He's the founder of the Italian neuroradiology. He's a pioneer in the field of medical use of X-rays early on. In 1917, he described the association between lumbosacral transitional vertebra and lower back pain. So this was the earliest terming of this transitional vertebra, which was later on termed after his name, the Bertolotti syndrome. His finding highlighted the importance of congenital anomalies as contributors to non-specific back pain or atypical back pain. He published his finding in his craniology lessons, 1920, in his studies on pneumoencephalography in 1934, and internal frontal endocriniosis. These are his major publications. So to begin with, defining this pathology, it's a congenital anomaly of the lumbosacral junction. It's characterized mainly by enlargement of the transverse processes of L5. These processes can enlarge and can articulate in some cases with the sacrum, forming a full fused segment, or it can form what we call a pseudo joint, or it can be just an enlargement of the transverse process of L5. And here comes the role of the Castellivi classification. I will describe it later about the different types and different subclassification. These anomalies alter the biomechanics, and they may lead to back pain and what we call atypical back pain. This is a radiological view of this pathology. So we have this elongated L5 transverse process. In this case, it's forming like a pseudo joint. This is a type Castellivi type 2B. Here comes the classification. Castellivi was the first to describe the classification of this pathology in 1984. He subclassified it into 7 types. Type 1, which involves an enlargement of the L5 transverse process up to 90 millimeter. On single side, this will be 1A. On both sides, that will be 1B. Whenever we start having this joint-like structure or a pseudo-articulation between the L5 and S1, on one side, we call it a 2A classification. When we have this pseudo-articulation on both sides, as shown here in this figure, this is a 2B classification. When we start having the fusion between the L5 trans process and the sacral ala, we start to term it as 3A on one side. When the fusion involves both L5 trans processes, that will be a 3B. And the last type will be a mixed type. So on one side here, we see on the right side a pseudo-articulation between the L5 and the sacrum, and here we have a total fusion of these two segments. The epidemiology of such a pathology varies. 4 to 8% in the general population was noted. The prevalence is higher in patients with chronic low back pain. It's often underdiagnosed due to the overlap of these symptoms with a lot of other pathologies. So these patients come with not only back pain, they come with hip pain, they come with SI joint pain. All these can mask it, and also, as I mentioned, underreporting of this pathology is very common. The case presentation, usually, as I mentioned, chronic low back pain that's often unilateral. The pain may radiate down to the buttocks or the thighs. This is mainly from the irritation of the L5 nerve root anteriorly at its location. The symptoms, as I mentioned, can mimic sacroiliac or discogenic pain. This presentation usually comes in mainly in young adults. This is a case we saw in clinic. This is an 81-year-old male. He was referred to us because of his history of lower back pain. Patient was treated with an L4, L5 laminectomy. He presented again with this lower back pain, non-specific leg pain, question mark hip pain. So when looking at this X-ray, we should always note these abnormal findings. This is on one side, we see this partial joint formation and Bertolotti on the right, also on the left side. And not only this thing, we should look at the hip joints. As you note here, these hip joints on the left side are bone on bone. So this patient was a great mimicker for us. So his pain mostly was due to this advanced osteoarthritis of the hip. This is his hip X-ray. Patient ended up with a hip replacement, and he's doing very well. An important thing to note when discussing Bertolotti syndrome and lumbosacral transitional vertebra is wrong side surgery. This is an interesting article published in 2020 in the Global Spine Journal that discussed this issue mainly. One of the most frequent causes of wrong level spine surgery is transitional lumbosacral vertebra. So these transitional vertebra can present in up to 40 to 30%, and they can be very challenging, especially when you're trying to number the vertebra counting from the sacrum up. So this transitional anatomy can blur our anatomy at L4, 5, 5, 1 also, leading to wrong level exposures mainly, and incomplete imaging. And this is mostly because of incomplete imaging. So one of the ways to prevent such thing, and the main thing, the whole wrong level surgery will be to obtain whole spine imaging and be consistent with counting. So we should always count from the sacrum up. The same counting that's done on the MRI should be also on the X-ray. We should also rely on the marked fixed bony landmarks like the iliac crest, sacral promontories, and those landmarks that we can see. Clearly, it's very important to document these lumbosacral transitional vertebra in our notes and imaging reports, and not only to rely on what was discussed by the radiology. The diagnosis is mainly, as you all know, based on the different imaging techniques. X-ray will show the enlarged transverse processes. CT and MRI will define the articulation and rule on other pathologies. The most important here is the use of the technician 99 bone scan. As you know, this patient has a very active spot at this left Bertolotti, shown on both this coronal and this is the axial CT scan reconstruction. This can hint to the pain generator and lead us to a correct diagnosis. The treatment of such pathology is similar to what we deal with in the lumbar spine, cervical spine, or any spinal pathology. This starts with the conservative management, including pain meds, anti-inflammatory therapy, physical therapy, and most importantly, activity modification. This is to begin with. Then we can go to more sophisticated things like the interventional techniques. Local anesthetic injections, steroid injections are important. Radiofrequency ablation, I will briefly talk about this thing in a few slides. And finally, the surgical resection, which we will also discuss in separate. The radiofrequency ablation for Bertolotti, the rationale behind this treatment methodology is that the pain mostly originates from the pseudo-articulation between the lumbosacral transitional vertebra and the sacrum/ilium. So our aim will be to ablate the sensory fibers around that pseudo joint. So the technique will confirm first the pain generator via diagnostic anesthetic/steroid injection. And when we confirm that site, we can target the sensory nerves around the pseudo-articulation and also the adjacent medial branches that supply this area. So the lesion will be done at 80 degrees Celsius for 90 seconds using bipolar or cooled radiofrequency ablation probes. The outcomes after radiofrequency ablation are quite promising. The reported pain relief is up to 7 to 16 months in case series by several authors mentioned here. And it's considered one of the minimally invasive options before going to the resection or fixation thing. I will end my slides with the case. This is a case we had surgery on back in my home institution in Beirut. We have this is a young lady who presented with the atypical lower back pain. The reported CT scan showed this Bertolotti syndrome. We confirmed the diagnosis with an injection, and we went down resecting this process using the MIS techniques. Patient, after the procedure, did very well, and she followed up in clinic, and she did very well. So this is one of the treatment modality we can, but of course we should make sure that this is the source of the pain generation for such a patient. This is the end of it. Now, I think Hagai will present the second part about the resection techniques for such pathology. Thank you.
Mohammed, can you hear me? This is Jens.
We hear you, Jens. Good to see you.
Hey. So I'm in the hospital gown here, and just hello everybody, and I'll make it very short because our fellows have a full program. So with this segment tonight, we want to again bring to everybody's attention Bertolotti syndrome and lumbosacral transition anomalies. Why? Because again, we have tons of fancy cases and technologies and robots and whatever, image guidance, but so often with this increased focus on SI joint pain now, we see patients who've been diagnosed with SI joint pain when they actually have a lumbosacral transition anomaly. And in my rare but present medical legal defense practice, I see a lot of wrong level surgeries done. I have even seen, this is for Dr. Ziegler, Geyer, and Blumenthal, the mavens of disc arthroplasty. I've seen surgeons try to put disc arthroplasties in these residual motion segments. Not a joke. Thinking that they're degenerated when they're basically just amorphous little residual discs. So this is why we thought, and our fellows really deserve credit for this, we should just do something very simple and go back to how many lumbar vertebrae do we have and what does a lumbosacral junction actually look like and what are actionable and non-actionable items. So that's the premise of this. So with this, I'll sign off and maybe ask for commentary by my dear friends from the Texas Back Institute.
Yeah, I'd like to make a comment and a couple questions. So first comment about the wrong level surgery, which most commonly occurs posteriorly. So what I used to tell the fellows is when you dictate say, a herniated disc over a transitional segment, rather than dictate the number L45, L5S1, because they may be referred to differently in the diagnostic studies, it's lowest mobile segment or second to lowest mobile segment, so that you're recognizing that there is transitional anatomy that might not be moving. So that's number one. The question is, and here are two questions. Number one is, are these really mobile segments? And I agree with Jens, like it's crazy to do an artificial disc in front of a Bertolotti's, because if they are mobile, they're minimally mobile, which is why we see more pathology at the level above. And then on one of the studies that was just presented by Mohammed is, oh, we have great results from radiofrequency ablation. It lasts up to 16 months. Like, is that a treatment? I mean, a treatment that gives you 16 months, and that goes back to the surgeon versus interventionalist pain management doctor. Same thing with posterior element radioablations. Oh, radioablations, they work great for a year to 2 years, but does that really take care of the problem? Again, I leave that's more of a question than a comment. But the fact that there's a study that says radioablations do great, they last for 16 months, to me, it's like, okay, that just doesn't make a whole lot of long-term sense for our patients' well-being.
Scott, if I can follow up, I just want to second his comments. You got to be very careful to document that your numbering system may be different than the radiologist's, and that using first or second mobile segment above the transitional is much more helpful than a number. But in the arthroplasty anterior lumbar world, two more things to consider is above a Bertolotti's, it's not unusual to see a very degenerated disc, because that essentially is the patient's lowest mobile segment and will tend to wear out. And we see a lot of post herniation or post laminectomy patients at that segment above. But the other thing is pointed out to me by my access surgeon is, when you see osseous anomalies, you need to look for vascular anomalies, because we've often seen the bifurcation at that level, above that level, below that level, different than you would anticipate. So always keep in the back of your mind that if you're going anteriorly, the vascular anatomy may not be classic if you are operating on segmentation anomalies.
All right. I just have a
It
couple
drives your
comments.
access surgeon crazy, because you're right. They don't know what they're going to get into, whether the one above a Bertolotti's is going to act like a 5-1 in the bifurcation, or is it going to be a 4-5 where they have to take the ascending lumbar. You just don't know till you get in.
All right. Just a couple quick comments. In addition to what Scott and Jack said, what I dictate is that the radiologist called this level X. However, I am calling it the first mobile lumbar segment. You got to be real specific. The second point is that depending on how rigid that articulation, if it's a pseudo articulation, you may still see a rudimentary disc that looks well hydrated, or you may have a total fusion in which it is a really rudimentary disc. Now, I've operated on patients on fusions on a degenerative disc where they had a pseudo articulation at the transitional level. So, it's not only coming just from the pseudo articulation, it may also be coming from the degenerative disc at that level. So these are tough, and you just have to be very careful in your selection and what you're doing. And I agree with Scott that, doing a radio frequency and getting 16 months, you really haven't treated the patient. You just bought them a little bit of time.
And also for the residents and fellows, in addition to dictating, lowest mobile segment, second to lowest mobile segment, I always dictate in my operative note that both the preoperative films were there and they were correlated with the intraoperative localizing films, particularly when you're doing a discectomy, when you haven't left hardware in there, and people can say, the next surgeon can say, oh, he was at the wrong level. If you have an operative note that documents you've got the preoperative studies, intraoperative, and you recognize that there's transitional anatomy, it's going to be a lot harder to scrutinize that, the second surgeon said you're at the wrong level when you were at the correct level. So the more documentation you can do in that operative note, and I'm sure Jack, Rick, and Jens will agree, It just makes it looks like you're aware and you took care of that potential issue.
Absolutely.
And I would add,
All right. Take it away, Seattle.
yeah, I was going to just add one last comment too, that reconciling all the different descriptions of the anatomy, whether it was a previous radiology report, and making sure that you recognize that, you reconcile the differences, obviously, in your note. Great comments. And I guess the last comment I'll make too is that in regard to radiofrequency ablation, at least in my review of the literature, it seems like a lot of this literature does come from pain doctors. And I wonder, it raises the question, where are these patients finding their way through the medical system? Are they finding themselves into pain clinics before they make it to a surgeon's office? And maybe in part that also dictates some of that treatment approach. So we'll jump to our next case.
Hi, thank you, Mohammed, for the great presentation. I'll be discussing surgical resection as a treatment option for Bertolotti syndrome. I'll begin with a case. This is a 28-year-old male. He came to our clinic a few months ago. He's been suffering from lumbar pain with radiation for several years. He was treated NSAIDs, painkillers. He failed several courses of PT with no improvement. On his lumbar CT, we can see pseudoarticulation of the L5 TP with the sacrum on the right. We sent him to get a SPECT scan that you can also see here, and you can see the red hot spot here. Sorry. Following that, we referred him to get a localized injection to this pseudoarticulation, and he got some short-term relief from the specific injection. So the question was, what should we do next? So the current literature about treatment of Bertolotti syndrome is relatively scarce. There's no RCTs. There's mainly small case series, retrospective studies. Two notable studies that I will mention today are one by Mikula from Mayo Clinic and Jenkins from Mount Sinai. These are the two largest studies, but still sample sizes are relatively low. If we talk about resection versus conservative treatment or even radioablation, like we mentioned before, so all surgical studies require referral of conservative treatment. There's no head-to-head studies comparing resection to ongoing non-surgical care, but that's pretty much the same with different surgical interventions. So there might be some bias towards surgical treatment in the published data. The first study I would like to present is maybe the first study done comparing resection and fusion of for Bertolotti syndrome. It's a study by Santa Virta from 1993. These are cases from 1978 to 1987. They had 16 patients, 8 underwent resection and 8 underwent fusion. The type of surgery was picked by the surgeon. They also had 16 control patients who were treated conservatively, but the results were not as good at the discussion part. The results, no significant difference, mainly. Back pain improvement was identical. Pain resolution was slightly better with fusion. Revision rate was identical, and the ODI scores were also identical. Overall, only moderately successful. So their conclusion was no better treatment, fusion or resection. Another point worth mentioning about this study, the patients who had temporary relief following an injection did not necessarily have relief following surgery. So using this injection as a diagnostic tool or as a guiding towards surgical treatment, I don't know if that's, we can't support this with this data at least. A more modern comparative study is the study by Mikulas done in Mayo Clinic in 2022. They presented 27 patients, 18 underwent resection, 9 underwent fusion. They made sure they had no other concomitant spine pathology. The type of surgery, again, mostly surgeon's choice, 70% of patients, some patient's choice, some other reasons. The primary outcome they measured was pain level, and the patients were followed up for a year after surgery. The main finding of this study is long-term failure. We can see with the resection, 100% of resection patients had short-term relief, but if we follow them for a year later, then they had about 72% failure rate, okay? So long-term relief only in the fusion patients, and resection patients had a high failure rate following a year after surgery. Are the results not equivocal anymore, like in the Santa Rita study? I don't know. Was there better follow-up? Was there different patient selection? Was the surgical techniques have evolved? Was the outcome measured differently? Yes, all of the above. So still no definitive answer. The next study is the study by Jenkins. Jenkins tried to establish a new algorithm for treatment selection. He came to define how can we choose a better treatment for Bertolotti. Should we resect or should we fuse? He took the Castellevi classification and changed it a bit. And basically, if the main change is, 10 millimeters instead of 19 millimeters in the Castellevi, but mainly we're talking about the differences between type 1 and type 2. Type 1 are narrowing of the gap, and type 2 are the pseudo-articulation or pseudo-joint. When they believe that type 1 patients suffer from the narrow TP-ala distance and therefore will benefit from section, and they say they had no patients with distance greater than 10 millimeters that was symptomatic at all. While type 2 patients with the pseudo-articulation suffer from abnormal joint movement, therefore might benefit from either resection or fusion. Type 3 patients, the ones that are already fused, don't touch them. That's their conclusion. Look elsewhere for a pain. They treated 65 patients. Type 1 patients, they had 13 patients that underwent resection, and type 2, they had 36 patients. At first, 18 underwent resections, and then 18 underwent fusions. The results. Type 1 patients had very good results following resections, with 85 overall improvement, low rate of revisions, quite similar to the type 2 patients who underwent fusion, but type 2 failed in a very high rate following resection. So much, they stopped offering resection as an option for this patient mid-study. If they began with offering type 2 patients either resection or fusion, they started offering them fusion only. Following revision of the resection or a primary fusion, the patients had equivocal or even better results than the type 1 patients that underwent resection. So their main conclusion is identifying the anatomical subtypes can help tailor a treatment plan that improves the outcome. Another last point I would like to address in this topic is the use of navigation in procedures. We talked about wrong level surgery. Again, when we go in to resect a Bertolotti joint or fuse it, we're dealing with pathological anatomy. Navigation system can help the surgeon with orientation and add some precision. There's not a lot of data on the subject. There's one small series by Babu, published 2 cases, 100% success. The cons of using navigation systems, I believe, are known and are the same in most cases, but maybe in this kind of cases, in Bertolotti syndrome, the pros might outweigh them. So to summarize, a careful assessment of the patient anatomy should dictate treatment selection, and navigation may improve the precision, and so consider using it. Patient should be made aware of higher failure rates with resection, especially when they have complex anatomy, type 2 anatomy, but still all treatments are lacking in evidence quality. So back to our case. In hindsight, I would classify this patient as a Jenkins type 2 with a pseudoarticulation. I think not different than the case Muhammad presented from Lebanon. Either way, this patient underwent resection. We went in and resected the pseudo joint on both sides, both the sacrum and the TP of the L5. We still don't have any short-term follow-up even. He hasn't returned to clinic yet. Hopefully, he will do good. Will Jenkins be right? I think the time will tell.
Did you
Thank
put
you.
any kind of a,
Sorry, go ahead.
I was just going to ask, did you put any kind of a barrier to prevent it from fusing again or
Bone
bridging
wax.
across?
Bone
Just
wax.
wax both ends?
Yep.
Yeah, in the old days, we used to put like a fat graft in there too. But I'll be curious for the faculty. So there's 4 or 5 of us, and I saw Randy Davis on the chat box. In decades of spine experience, how many surgeries on Bertolotti's have you done in your career? I would say for me, like 1 or 2. Jack's got a big 0.
I've done one, I've done fusion, and I think part of the problem why these early data look so terrible that, resecting a pseudoarticulation, there's no mention of what the disc looks like. A lot of the studies were very early on before we even looked at the MRI scan. So, we really don't have a good treatment. I think you have to look in the front and the back, meaning that, look at the disc as well. If it's a really rudimentary disc, then, there's nothing there. But if it does have a disc there, then you have to look at that and, consider diagnostics. I think that you can see the poor results we get from resecting them.
I mean, it's fascinating. Randy said 2 out of 8,000. I mean, it's really interesting because we treat some unbelievable pathology. I mean, huge deformities, tumors, trauma, high-grade spinal stenosis with instability. And this is kind of pretty minor in the world. And, the patients that we treat with pathology get better for the most part, but no one really gets 100%. It's like, how many patients do you have come to clinic and say, I am 100%? And that's the problem, is you got these Bertolotti's patients that have 3 out of 10 back pain, and you do these operations and they come back and say, oh, I'm better. I'm 2 out of 10. Like, okay, is that really better? I don't know. This is kind of fluff, I think.
Well, I think, Scott, we just don't have the diagnostic. Like I said, nobody looks at what's happening with the disc. And, we've all seen them where sometimes the disc is a dark disc, it's degenerative, even though it's rudimentary. Now, is it the source of pain? I'm not saying it is, but to just focus on one area because they got a good relief, it's like, us evaluating somebody for an artificial disc. We do, facet injection to get a rhizotomy. They don't get any better. They have a bad disc in front. We put an artificial disc. I'm just saying that I don't think that the diagnosis is clear in these patients.
Yeah, and I agree. I mean, like the barrier for improvement with these is pretty slight. I wish Izzy was on, because he's got some really cool cases using the Mazor and doing these way targeted, minimally invasive robotic things that, at least if you're going to do something, you do it through a very minimally invasive portal.
And I think you also have to wonder how many of these failures were because there was other pathology. And, and a little bit of the blind man and the elephant, I've seen a lot of patients and operate on a lot of patients who have that transition level degeneration breakdown above a Bertolotti's, and never even, worrying that the Bertolotti's is the #1 producer. And we seem to be having a relatively good success rate doing that, versus 50-50 at best, with this procedure, which, I did 2 coccygectomies early in my career. And just like Randy Davis commented, one did well, one did badly. And I figured this is not worth it for 50%, and never did any more. And I kind of put this in the same basket, unfortunately. But I think there is other pathology in a lot of cases.
You know,
And I
Jack,
think
we
you're
were
right. I
hoping to
think
make you
perhaps,
the cholecystectomy expert.
yeah, I mean, I think you're right. I think perhaps the importance of the Bertolotti's or the transitional anatomy is how it transitions the forces and the advanced degeneration to the next level. Because we're treating a lot more next level pathology to transitional slash Bertolotti's than actually the transitional slash Bertolotti's itself. It's how, so I don't know. Jens is about to say something. I can see him. No? Okay.
A quick
We should
question,
move
actually,
on.
from
We
my
should move on.
perspective. Oh, uh,
But yeah, go ahead.
have you
Yeah,
been
Jens.
using technetium studies, these for assistance with diagnosis?
I mean, if it lights up, I agree. I think that, at least that gives you some positive information. And I don't know that all the studies use the bone scan to pick it up, but if it's hot, you would think that would be a source of inflammation and pain. It would be interesting to see those studies that were done only on those that had the hot technetium scans.
Love to see a session, one of these evening sessions just on SPECT CT because there's there's a dearth of literature on SPECT CT, but there are a lot of places in the country that use SPECT CT to say, oh, it's lighting up in the disc space. I need to do a disc operation. It's lighting up posteriorly. I need to do a posterior operation without a whole lot of backup in the literature. So it would be an interesting discussion point some evening to talk about just SPECT CTs.
Since we have the three maidens, we have two more presentations. One good one bad one. Sorry, my voice is raspy from my intubation earlier. Is a disc replacement and a symptomatic disc above a transitional vertebra a legitimate procedure or not? Let's say you have a semi-ankylosed 5-1 segment, there's no hot transition zone. If that 4-5 segment is wasted, is that an okay indication to consider a disc replacement? We have the three worldwide maidens there.
Yeah, absolutely.
I wish I had my case. I did one, Jens, I did one today, which is exactly, it was above a Bertolotti's. It was a trashed out 4-5 lowest mobile segment. Interesting enough, my access surgeon did it in the bifurcation. So to Rick's point, the vascular anatomy was more 5-1. But yeah, I mean, I think it's a great indication if you've got advanced degeneration above these transitional segments to treat that. If you feel like there's no other, if you feel like that's the pain generator.
And Jens, I actually had a case where it was just a pseudo articulation, not fused, so type 2. And we did discography, and the disc had a relatively well-developed disc, and it was a degenerative disc. And at the level above, also degenerative disc. We did discography, got reproduction at both levels. I did an ALIF at the Bertolotti's level, and I did a disc at the level above. So that's why I'm saying you have to look at the signal of the disc if it's a well-formed disc. If it's rudimentary, then you don't do anything.
Jens, in a healthy upper 30s or mid 40s-year-old, it's a lot better than doing a fusion above this and leaving them with only 3 mobile segments for the rest of their life. Because the Terry Marnay saying that the day you do that, you sign the death certificate for the next level. You just leave the date blank.
Yeah, I don't see why you would want to do a fusion at the level above anyway, if
A little
indicated.
plug for our arthroplasty forum. The big three are going to be there in the near future. Corey, maybe you can put the link in, and please come. Maybe we can show some of those cases because there's so many nuances in there and details, and we have the masters there. So, Mark, shall we proceed with the next presentation, or as a follow-up from Hagai?
Yes, we'll switch over to Mohsen next.
Mohsen, can you introduce Mohsen? Yeah, Mohsen Karami from Tehran, great fellow, orthopedic background. And Mohsen, you pulled the short straw. You have to present a theory of mine. If we can't get it up, shall we switch to Oliver? Or is it coming up?
Good afternoon. I'm very glad that I'm part of this discussion. It's a very interesting topic. Honestly, there is no high level of evidence about correlation between low back pain and Bertolotti syndrome. So I'm going to discuss about fusion as a treatment for Bertolotti syndrome. So we had a patient here, 56-year-old female. Her chief complaint was back pain, severe back pain for about 3 months, left-sided hip pain for about 5 years. Was not able to walk without the walker, and physical activity for her was like very terrible. Wasn't able to walk and do any physical activities. Was on multiple medication, including oxycodone. She had, in terms of past medical history, she had ulcerative colitis, taking mesalamine to avoid flare-ups, and doing job work, desk job work, and was not non-smoker. In terms of functional scoring of the patient, her back disability score was about 56 before the treatment, and depression score was about 60. Pain was about 68. And in terms of physical exam, there was like a little bit of foot drop both sides, and was not able to do any squatting and performing to or heel walking. This is the X-ray, standing X-ray of the patient. So you see that there is escalating vertebra at the bottom of the spine. And she was osteopenic, not osteoporotic. So you see here on the lateral spot view of the spine, there was like L3, L4, mild displacement of L3 over L4 and L4 over L5 listhesis. And when you take a look at the spot view on the lumbosacral area, you see that on the left side, there is kind of probably a fusion between TP of the L5 and sacral ala. And this is the MRI of the patient. You see there is spinal stenosis, lateral recess stenosis at L3, L4, L5. And on the CT scan, we see stage 3, type 3 of Castle-V classification. And CT myeloid clearly shows spinal stenosis at 2 levels. So we were discussing about the treatment. Basically, for this patient, probably having transitional vertebra, but wasn't the cause of the back pain. Probably was the pain was related to the spinal stenosis and displacement of the spine because of the degenerative facet zones. So we tried to do decompression and L3 to pelvis fixation, including cage insertion and 360 fusion bilaterally. But the thing is, after 6 months follow-up, the patient was still in huge pain, wasn't happy about the surgery results. And then take a look at the scoring. Hair pain, like disability score was like 56 after 6 months. Hair pain and disability score was worse than before surgery. But when you take a look at the foramen, they were open, widely open after the surgery. So we didn't understand what was the reason for that, high disability scoring of the patient. So finally, the patient fired the treatment team, including us. So why fusion fails? So fusion is like big surgery for that kind of pathology. So probably incorrect patient selection. We didn't want to treat the Bertolotti syndrome because that was type 3. So we don't usually select fusion for type 3. We should make sure that the pain is not from L4, L5, and there is no pseudoarthrosis as well. And wrong level of fusion can worsen the outcome as well. If there's pseudoarthrosis, we have to do a block, just make sure the pain is, is from that spot. If there is more than 80% of improvement after the injection, we can, predict surgical outcome after fusion. So the ideal candidate for this fusion could be Castle type 2 or 3, pain localized to pseudoarticulation, dramatic block pain relief, intact L4-5 disc, and failed conservative treatment. So as a conclusion, fusion is not the first-line treatment for sure, and we have to make sure that there is a clear indication for the surgery, and diagnostic block is very important as a key to success. Thank you.
So I'm responsible for this. I take full discredit for this. Dr. Karami, most beautiful presentation. Can you hear me? Can you hear me okay? Can you hear me okay?
I can hear you.
Yeah. So beautiful presentation on a difficult case. I take full credit. I did try to do a posterolateral fusion into the pelvic crest. Miserable. There was nothing in surgery. It's a nice, clean surgery. Yes, all posterior. We have great people online. My three wonderful colleagues from TBI and Randy Davis and Michael Heisey. There are many others. Fire away at me. What did I do wrong? I really tried to prehab her right most, and I spent like half a year with her trying to get her off opiates. But this is an abject failure. I failed in her. I don't know. Wrong patient selection, technique. Should have done anterior. Fire away. Go for it. Speechless, everybody. Then we can go for a good case. We can go to the good case and discuss both together. Shall we do that? There is hope. There is hope.
All right, well, we showed a case that failed, and here's will be a case that was successful. We kind of went over this a little bit. This is some of the conservative management for Bertolotti's. A lot of it's similar to a lot of the, the low back pain patients, activity modification, physical therapy. I'm just going to blaze through this. We don't have that much time. Medications like NSAIDs, and then the injections that we talked about, corticosteroid injections, as well as radiofrequency ablation. And again, as we spoke about, there's so many studies, there's not so many studies really looking at this. And some of the studies that I did find, conservative treatment was able to help improve function 50 to 70% of the time, but long-term resolution was only 20 to 30%, and failure of a conservative management was 30 to 40% that then would require surgery. And basically in the end, as Mohsen and my other fellows have said, if symptoms persist beyond 6 to 12 months, that's when we start really considering surgical options. So a case here, this was a 50-year-old man. He had presented with back pain, leg pain, and paresthesias. He had bilateral sacral insufficiency fractures. He had left buttock pain. He also had low back pain and bilateral radiating lower extremity pain, right, greater than left. This guy was a really hardworking gentleman, worked at a warehouse. Did a lot of heavy lifting, just a salt of the earth guy. This was his exam here, full strength throughout, no pathologic reflexes. He did have a slight decreased sensation in the right lower extremity and the outer lower right leg. So we ended up getting some pictures here, his x-rays, flexion extension, as well as his AP view, and you can see obviously L3, some pretty bad disc disease, as well as his spondylolisthesis. These are some of his parameters. His PIL mismatch was pretty good, 6 degrees. SVA was only 1 centimeter. And then looking at a CT here, we saw again that L3-4 level with some severe disc degeneration, as well as the listhesis, very tight foramen here at that L3-4 level. We ended up getting a bone scan, and what we saw was, obviously the 3-4 lighting up a little bit, but also that left joint lighting up here. And this is just a video of that CT.
Why a bone scan?
The left buttock pain.
Why? I still don't see what the bone scan added. I assume this is
he had the sacral insufficiency fractures, and with the buttock pain, we wanted to look at all those areas to see if it was hot or not. This was his DEXA scan. He ended up being, with the femoral neck, he was mildly osteopenic. And here, sorry, the slides, oh, there we go. The slides, here we go. These are his, looking closely at his coronal CT, you kind of see this enlarged transverse process on the left and right. And he had the obviously stiffened L5-S1 level. So again, overall, this guy, 50-year-old guy with bilateral sacral insufficiency fractures, left SI joint arthropathy, and a spondylolisthesis at L3-4. So what would be the plan here? Obviously, multiple areas of issue. And what we ended up doing here was a L3-4 interbody fusion with a combined left-sided open and percutaneous SI joint fusion as well. And you can see those post-op x-rays here. And luckily, this gentleman was actually a big success. So his pain scores pre-op, he had a 52 of his ODI, which went down to 6 post-op. So he was doing a lot better, his ODI, and then his pain scores also went down. And those are some of the references for the Bertolotti's conservative management.
single-time surgery, both treating the SI and the L3-4?
Yes, simultaneous surgery. So Mohsen, can you come up and keep that up? So I'm happy to be criticized. I'm happy to be second guessed.
Jens, why didn't you just do 3-4 and see what happens?
This is where, for me, the bone scan is so important in the clinical exam. This guy could not do something that I love to do, which is totally unpublished for SI joint pain. He could not do a single leg hop test on the left side. Right side, no problemo. Left side, ouch, can't do it. And this is a very tough guy.
Yeah, but so clinically, if you said, okay, he's got this L3-4 problem, we got to treat that, but I'm really worried about this unilateral sacroiliac insufficiency defect symptomatic, and they point their finger and say, I hurt right there. Does the bone scan really change what you were going to do? I mean, if clinically it's like that was my other pain and they had pathology there, did the bone scan really change what you were going to do?
Totally. I would have done a bilateral SI joint fusion had he lit up bilaterally. I would have done nothing and said, let's just treat the obvious pathology at 3-4. Had this bone scan not been this bingo thing on that very side. Had it lit up at that pseudo articulation at Castelvi 1B, if I get that right, or 1A on that left side, I would have probably talked him that this is getting a real problem. I would have had to possibly fuse 5-1 to the pelvis, which we saw in the preceding case by Mohsen, failed. And then we would leave a single level motion segment intact at 3-4 between a necessary 3-4 fusion. Sorry, at 4-5. So there was a lot riding on it for me, and I thought this was very helpful. And I can really state this patient has been incredibly grateful and gone back to full physical labor with a single level fusion, which I feel good about. But again, I failed in the preceding patient where I was similarly very careful. I thought I did my due diligence and fired.
Jens, I think you showed remarkable restraint. I think a lot of people would have done, L3 to the pelvis and not even thought twice about it. So the fact that you addressed, focally, even those two different areas, and got God gave you a good outcome because I think you did the right thing for this guy. Not so sure about the other case.
No, I agree. I think it makes me think about in complicated multi-site pathology, maybe I'm not using SPECT CT or bone scans enough. I mean, I think this brings up some really good points.
This patient had erosive sacroiliitis. It was a bad arthropathic joint in addition to insufficiency fractures. So it's not surprising the bone scan lit up there.
I agree, but in terms of choosing your your weapon. Like Rick said, why not just do 3, 4 and see how it happens? What happens? Yeah, I mean, if you've got like a hot potential pain generator of, that the bone scan or the CT spec seems to indicate, then I think there's good justification for doing both. And like this case showed, home run.
And Jens, make another couple comments. So, the bone density scan was normal, the lumbar spine, but he had terrible degenerative changes. He had insufficiency fractures at the sacrum. So when you did the SI fusion, were you treating the SI joint, treating the fracture, or the pseudo articulation?
Great question. So our spec, our spec CTs are so differentiated now that I can differentiate ongoing fracture pathology in the CT modality from the SI joint. This patient, as Jack had identified, had SI joint pathology. He had a sacroiliitis, a sterile sacroiliitis, a post-mechanical disruption, I don't know what, but he had that. So I felt comfortable, and I talked to the patient about all these options. By the way, I talked about L3 to pelvis, like what I did in the failed patient, versus just a very selective repair of the clearly identified pathology. So for me, that he had no ongoing fracture pathology in the sacrum itself, in the ala on both sides, was very reassuring. We concentrate on the pure pathology, and with the reassurance that L5S1 is stiff but not metabolically active, that was again for me a very reassuring thing that we could leave 2 motion segments reasonably safely intact. Mind you, the L45 disc is dysmorphic. I don't understand why. L5S1 is not beautiful, but so far so good. Have I bottomed?
No, Jens, you did a great job. My only criticism, you're trying to talk with your raspy voice and you just got over your procedure. Give yourself a break. You did a great job.
Why did I fail in the previous patient? Have that in the last couple of minutes. Tell me what I did wrong. Too much surgery? In the previous surgery that I showed in Mosen's case, Mosen presented that case that failed. What did I do wrong? She's very unhappy. No neurology, nothing. Very unhappy.
That's fine. Yeah, it's like there are a lot of cases where we think we do everything perfectly by the indications, and the patients just don't. I mean, it's just the field we're in.
I mean,
I wish
you
we were. I
carpet
wish we were
bombed.
more precise. It's diagnosis, and we're not precision level of diagnosis that other fields are in.
Yeah, and it really is a shame. Here it is, 2025. We're so sophisticated. We have all this navigation. We have, all this, other high tech. And here we can make a simple diagnosis in some cases.
Anyway, this is, let's let Dr. Chapman rest. This was not a sexy topic, but it turned out to be very interesting and stimulated a lot of good discussion. So we thank you. And I just want to leave you with some good orthopedic trivia. When I was a medical student in Syracuse, the seminal paper on the use of technetium-99 for bone pathology was published by the radiology group there. And the second or third author on that paper was the father of Paul McAfee. It was Paul's father, who was a radiologist. So that's a great piece of trivia.
Wow. Okay.
Well, anyway, you guys
So-
did great. And Jens, you went above and beyond. You really didn't have to do it, but you get some rest tonight. And thank you all the folks from Seattle. We appreciate it, or Swedish that is, and see you next time.
And we'll see you all in person in 2 weeks too.
That's right.
Right. Good night, everyone. Take
Bye.
care, Randy.